That'll be great. Oh, live now streaming on YouTube. So
Yes.
which one are you going to watch then? The parliamentary session or the this College of Physicians webinar? Actually. So they have a few options, couple of options there, right? I also sometimes take an opportunity to watch the parliamentary session there. Quite interesting actually.
Yes.
Should we start, Avinash? Already 3?
Yes, we can start. It's 3 o'clock. So good afternoon, everyone. Welcome to the weekly webinar hosted by the College of Physicians. My name is Abinash from Hospital Taiping, Perak, and I'm privileged to announce our extinguished speaker for today, Dr. Muhammad Amin. And I'm very humbled to introduce the chairperson for today. Dr. Jamalul Azizi bin Abdul Rahman is the head of service for respiratory medicine in Sedang Hospital, which is the national referral center in our country. He's got a lot of interest in advanced interventional pulmonology and robotic bronchoscopy. He was humble enough to ask me not to tell all of his achievements and accomplishments, but it's not fair to not mention a few. He's the president and the chairman of the program director for MABIP, and there's an upcoming event coming soon, which we will share further later. And without further ado, we welcome Dr. Jamalul Azizi. The floor is yours, Dr. Jamalul.
Okay, thank you very much, Dr. Abinash, for that kind introduction. Now, give me great pleasure to introduce our well-known speaker, Dr. Muhammad Amin Ibrahim. And of course, now there are about 50 participants joining the webinar now. So welcome to this respiratory webinar. And we are really privileged to have Dr. Muhammad Amin Ibrahim, who is a respiratory physician at UITM Puncak Alam. Correct. But I do understand that I think his place of practice has sort of changed a little bit lately. So, but I'll leave it to everyone to Google his name. You'll find his new place of practice. Just very briefly about Dr. Muhammad Amin Ibrahim. He's a respiratory and internal medicine physician, also a senior medical lecturer, and he is also the head of respiratory unit. Wow! In the Department of Internal Medicine, Faculty of Medicine, UITM, Sungai Buloh campus, Langodaro Ihsan. And he is still very young. He is not 40 years old yet, right? And he's married. And that's briefly about his qualifications. He graduated from Northern Ireland, from the Queen's University, Belfast. Right? Am I right?
Yeah.
And he did his internship there before returning home. Then did his master's in internal medicine at UITM, and so you will hear a bit of Northern Ireland accent in his talk. All right, and then after becoming a general physician, he did fellowship in medicine, and I was really fortunate to have him as one of my trainees in Sedang Hospital. And now I think he's a fully fledged respiratory physician, pulmonologist. And his talk is going to be on some common condition, chronic obstructive pulmonary disease, COPD. He's going to look at the recent update taken from the goal guidelines some of us may be aware that there have been some changes in the classification of COPD. And I think last time we were told there were A, B, C, and D groups, and now the classification has been shortened to only A, B, E. So I think I also will need to update myself. Without further ado, then I would like to invite Dr. Muhammad Amin to speak on Goal 2023 ABE assessment. Dr. Amin?
Okay, Assalamualaikum warahmatullahi wabarakatuh. Welcome to everyone. Thank you, Dr. Jamalul, for the kind introduction. First of all, I would like to congratulate College of Physicians Malaysia for having this series of webinar for this month. The webinar is focusing on respiratory diseases, and today we're going to talk about the Goal 2023 ABE assessment. One of the key changes introduced by Goal Committee in the latest recommendation. So my name is Dr. Amin. I'm a respiratory physician based in UiTM. For the next 40 minutes, I'm going to present on COPD definition. What are the causes and risk factors of COPD? How we diagnose and assess COPD patient? What are the latest prevention and maintenance therapy for COPD patient? And finish off with how we monitor and follow up COPD patient. My presentation is based on the latest Goal 2023 recommendation, which recently published in end of 2022. My presentation is based on management of stable COPD patient. I will not present on acute exacerbation of COPD. I try to make the presentation as simple as possible, so our colleagues from primary care, the clinic kesihatan, private GP, and our MOs from district hospital and non-respiratory doctors can benefit from this webinar. Going to start with a definition of COPD. COPD is defined as heterogeneous lung condition characterized by chronic respiratory symptom. The commonest symptoms of COPD is three: shortness of breath, dyspnea, cough, and sputum production. In COPD, there is abnormality of the airways as well as the alveoli, lung parenchyma. So in COPD patient, there are abnormalities of the airways and the lung parenchyma. Previously, COPD is also known as COAD, chronic obstructive airway disease. However, this definition is no longer true, because we know that COPD patients have both abnormalities of the airways and lung parenchyma. One of the key features of COPD is the symptom is persistent and often progressive, and these lead to fixed airflow obstruction. In contrast, if you look at almost similar presentation, asthma, the symptom often varies, and the airflow limitation will be variable. We look at the old definition of COPD based on Goal published in 2025, almost 8 years ago. COPD is defined as preventable and treatable disease. Again, the symptom is similar, is persistent airflow limitation and usually progressive. The old definition defined COPD as chronic inflammatory response in the airways and the lung. So in the latest definition in year 2023, the definition of COPD after 2015, after that, COPD is no longer defined as chronic inflammatory response. This is important because we no longer define COPD as inflammatory disease. Therefore, in terms of management, we have to be very selective when we want to give inhaled corticosteroid. If we compare to asthma, asthma is a chronic airway inflammation. So asthma is a disease of the airway. In asthmatic patient, the lung parenchyma or alveoli should not be involved. If there is abnormal lung parenchyma or alveoli, you may like to reconsider the diagnosis of asthma. The symptom is almost similar to COPD in asthma: wheeze, shortness of breath, chest tightness, and cough. The difference between asthma and COPD: in asthma, the symptoms vary over time and intensity. If we do the spirometry, there is variable expiratory effluent limitation. In contrast, in COPD, there is fixed expiratory effluent limitation. Causes and risk factor of COPD is combination of three things: genetic, environmental exposure that occur over time. So we call it genomics. Some patients or some individuals, they have abnormal gene to begin with that lead to abnormal lung development. So the lung volume at the peak is much smaller compared to other individuals. In fact, over time, the lung function decline is much faster compared to other normal individuals. In terms of environmental exposure, the known causes of COPD is tobacco smoking. But bear in mind, in our Asian population, there's also high exposure to biomass fume that can lead to COPD, especially in female patients. Other risk factor will be occupational exposure and outdoor air pollution. And this graph shows that how does our lung volume changes over time. So in terms of lung maturity or the lung growth, the lung volume, the lung keep growing or mature till the age of 20 years old. When it reaches its peak, after that, the lung volume will decline over time. So if you look at in certain group of individuals, because of genetic risk factor, because of exposure in early childhood, for example, recurrent chest infection, or nowadays the use of vape, especially in young adolescents, resulted in a smaller lung volume in this group of patients. So to begin with, the lung volume at the peak is much smaller compared to other normal individuals. So this group of patients, they are at the higher risk of developing COPD over time. And as this individual age, the lung function or the lung FEV1 will decrease over time. So there are certain individuals, because of the genetic risk factor, because of early exposure to smoking, vape, and recurrent chest infection during childhood, their lung volume is much lower at the peak, and this group of patient will have higher tendency to develop COPD compared to other individuals. Asthma also is a known risk factor for COPD. Asthmatic patients have 20 times higher risk of having COPD compared to those without asthma. In fact, 1 in 5 asthmatic patients have irreversible effluent limitation. By right, COPD, by right, asthmatic patient, they should have reversible or variable effluent limitation. And for asthmatic patient, in normal asthmatic patient, there is no involvement of the lung parenchyma. But in 1 in 5, 20% of asthmatic patient, there is reduced diffusing lung capacity or reduced gas transfer, indicating there is lung parenchyma involvement. In fact, self-reported asthmatic patients have excessive loss of FEV1 compared to general population. A study examining the pattern of lung growth decline in children with asthma found that 11% of these children meet the lung function impairment consistent with spirometric classification of COPD in early adulthood. So asthmatic patients, they will have smaller lung volume and greater decline compared to normal population. So this group of patient, asthmatic patient, at a higher risk of developing COPD as they ages. ABE hyperresponsiveness was the second after cigarette smoking in the leading risk factor for COPD, accountable for 15% of population attributed risk. About 15% of COPD patient, the risk factor for that is hyperresponsiveness. The first leading risk factor is smoking cigarette, which account up to 39%. Therefore, separating asthma from COPD in adult, most of our respiratory physician, we are dealing with adult patient. Sometimes it's difficult to differentiate between asthma and COPD when they first encounter to us. And how we diagnose and assess COPD? So the diagnosis of COPD consists of three things: based on symptom, identifying the risk factor, and lastly confirmed by spirometry test. So the commonest symptom of COPD will be three: shortness of breath, chronic cough, and sputum production. The risk factor that we want to ascertain during the history taking is number one, a history of recurrent lower respiratory tract infection, and number two, exposure to risk factor, namely tobacco, smoking, and biomass fume exposure. Don't forget that, especially in our local population. And how we confirm COPD is we perform forced spirometry. The difference between asthma and COPD, in COPD, we want to do post bronchial dilator FEV1 over FVC ratio. And for COPD, the value should be less than 0.7, indicating there is obstructive pattern. Remember that for COPD patient, we want to do post bronchial dilator FEV1 over FVC. In terms of assessment, again, there are three things that you're going to assess in COPD patient. Number one, spirometry to confirm the diagnosis, as well as to assess the severity of the airflow obstruction. Based on the FEV1, you can grade the COPD. Second is to assess the impact of the disease in terms of symptom. There are two ways to scale the symptom, to score the symptom. Number one is using the Modified Medical Research Council or MMRC dyspnea scale. And second scoring is COPD assessment tool or CAT score. And the third things that we want to assess in COPD patient is future risk of event, either in terms of COPD exacerbation, hospitalization, and death. I'm going to go through one by one. The other things that we want to assess in COPD patient, especially those who have persistent symptom after the initial treatment, the other assessment should include lung volumes, diffusion capacity, exercise testing, and lung imaging, either chest X-ray or CT scan. Don't forget, most of our COPD patients, they have concomitant chronic diseases. The common comorbidities of COPD patients are cardiovascular diseases, skeletal muscle dysfunction, metabolic syndrome, for example, hypertension, diabetes, osteoporosis, especially high usage of steroid due to frequent exacerbation, depression, anxiety, and of course, lung cancer, especially those who are elderly. We take history, we assess the patient. These are the things that indicate patient likely to have COPD. Number one, in terms of symptom, is shortness of breath. And usually the shortness of breath progress over time, worsen with exercise, and persistent. There is recurrent wheeze associated with shortness of breath. Besides shortness of breath, patient may present with chronic cough. Either it can be intermittent or unproductive. There is recurrent lower respiratory infection, and of course, do not forget to take history of risk factor exposure, namely tobacco smoking. These are the differential diagnosis that we have to consider when we are dealing with COPD patient at the first time. Either patient having asthma, congestive heart failure, bronchiectasis, tuberculosis, obligatory bronchiolitis, or diffuse bronchiolitis. How we can to differentiate either patient having COPD or other differential diagnosis is based on the history. Look specifically at the presenting symptoms and try to elicit the risk factor and clinical examination. Based on these few things, you can narrow down the differential diagnosis. After that, you can confirm or exclude the diagnosis using simple tests, either spirometry, chest X-ray. In some cases, you may have to do CT scan. Again, how we differentiate this? You have to begin with a good clinic history taking. This graph show how a normal spirometry looks like. In normal spirometry, the graph over your left side show that the value of FVC and FEV1 both were normal, and we do the ratio FEV1 over FVC, the value is more than 0.7. In contrast, those who have COPD and perform spirometry, some patients the FVC will be normal, some patients the FVC will be reduced due to the air trapping, and of course the FEV1 will be greatly reduced. We do the ratio FEV1 over FVC, you can see the ratio is less than 0.7, indicating that is obstructive airway disease. For spirometry, again for COPD patient, you want to do post-bronchodilator spirometry. In addition to diagnose COPD, spirometry also is performed to assess the severity of airflow obstruction, because it closely correlates with prognosis. In some therapeutic decision, for example, in usage of pharmacological treatment, especially when there is discrepancy between spirometry findings and the level of symptom. In some patients, we like to consider alternative diagnosis, again, when the symptoms are disproportionate to the degree of airflow obstruction, and for non-pharmacological intervention. In these circumstances, you like to do spirometry as well. And do not forget, when there is rapid decline of symptom and lung function test, you want to do a spirometry to monitor closely this patient. And spirometry machine used to be very bulky. The reading or the result is black and white. It's only black and white in color, printed on the carbon paper. Now the spirometry is getting smaller, become more portable, and of course the price is getting cheaper as well as the technology improve. Now, for example, we have handheld spirometry with a display on the device itself. Now, the new spirometry now can be connected to the computer or laptop using a wired connection or wireless connection. Hopefully, with these new technologies, the spirometry tests are widely available in our healthcare facility. Based on my experience, I think Dr. Jamal experience as well. Now, unfortunately, some patients they have to travel to certain hospital or just to do spirometry test, because the test is not widely available in our clinic, Satan or district hospital. In the future, hopefully, this test will be widely available in our healthcare facility. In addition to have the machine, the other challenges of performing spirometry in our local setting is to have the technical expertise of performing the test as well as interpreting the spirometry result. There are few spirometry workshops going to be organized this year. For those who stay in Sabah, there will be a spirometry course organized by respiratory department in Queen Elizabeth Hospital end of this month on the 27th and 28th of February. Those who stay in Klang Valley, you can join UITM Lung Physiology Masterclass organized on 3rd and 4th March in our new hospital in Puncak Alam. And those stay in Klang Valley as well, there will be another spirometry workshop organized by MTS in May. If you are interested, please join this workshop. Then you can know how to perform the spirometry test in good quality and acceptable manner, and hopefully you can interpret the spirometry test. Okay. Once we do the spirometry, can confirm the diagnosis based on the FEV1 over FVC less than 0.7, then can further grade the COPD severity based on the FEV1 predicted value. Those who have mild disease, when defined as FEV1 predicted value more than 80%, moderate between 50 to 80% predicted value, severe, those have FEV1 between 30 to 50% predicted, and those who have FEV1 percentage predicted less than 30 is defined to have very severe goal 4. In terms of symptom, the first questionnaire that you can assess the severity of symptom is using a modified medical research dyspnea scale, almost similar to your NYHA score. So grade 0, indicating that patient is less symptomatic and having no symptom, and the higher the grade, grade 4, patient is more symptomatic. I think you can try to memorize this grade. However, I think it's easier just to have this questionnaire in your clinic. So this is the MMRC dyspnea scale. In this questionnaire, it just focus on shortness of breath. But if you look at the other questionnaire to assess COPD symptom, which is the CAT score, it look at more comprehensive symptom. There will be 8 items in this questionnaire. If you look at the first 2 items, assessing patient cough, the next 3 symptoms, assessing patient shortness of breath, and the last 3 items looking at the patient quality of life. The higher the score, there will be, each question is grade 0 to 5. The higher the score, the more symptom a patient have. So the total score is 40. Yeah. So the cutoff value is 10. So if patient have more than 10 in terms of CAT score, patient is symptomatic. Again, you should have this questionnaire in your clinic when you're dealing with your COPD patient. In terms of future risk of exacerbation, study has shown that frequency and severity of COPD exacerbation is closely related to COPD mortality. If you look at the graph over your left side, Kaplan-Meier survival curve by frequency of exacerbation of COPD. So we divide patient into 3 groups. Group A, patient does not have any exacerbation. Group B, those who have 1 to 2 exacerbation that require hospitalization, and group C, those who have 3 or more acute exacerbation of COPD. The higher, the more frequent COPD exacerbation that patient have, the less likely that patient going to survive in the future. So frequency of exacerbation is closely related to COPD mortality. Second is the severity of the COPD exacerbation. You look at the second graph over your right side. This Kaplan-Meier survival curve looking at the severity of exacerbation in COPD patient. So in group 1, there's no acute exacerbation of COPD. In group 2, patient with acute COPD exacerbation, but they only require emergency visit with no hospital admission. And group 3, those who have acute exacerbation of COPD that require hospitalization. And last, group 4, those require readmission. The more severe the COPD exacerbation, the less likely that patient going to survive during follow-up. So both frequency and severity of COPD exacerbation are closely related to COPD mortality. Amphibious exacerbation also correlates with the COPD mortality. In this study, show that in group A, those who have no acute exacerbation. Group B, those who have 1 to 2 acute exacerbation per year. And group C, those who have 3 or more acute exacerbation. You compare group A as your reference value. So group B, those who have 1 or 2 exacerbation per year are 2 times more likely to die compared to those in group A. And of course, group C do have 3 or more exacerbation per year. They are 4 times more likely to die compared to those who never have COPD exacerbation. FEV1 as baseline also predict future COPD exacerbation. So goal 2 defined within 50 to 80% of FEV1 predicted. Group goal C within 30 to 50, and goal 4, which is less than 30% percentage predictor. The severe, the lower the FEV1 predicted, the more likely patient going to be hospitalized for COPD, as well as the more frequent COPD patient that going to be experienced by patient. This is another study. In this study, show that previous exacerbation are strong predictor for future COPD exacerbation risk. So in this study, they recruited about 1,679 patients. They follow up patient over 3 years, year 1, year 2, and year 3. Those who have no exacerbation in green color, the second group, those who have one exacerbation in gray color, and those who have 2 or more exacerbation is in orange color. And we follow up patient year 1, year 2, and year 3. You can see those who have no exacerbation in green color, they remain the same over the 3-year follow-up. And those who have frequent exacerbation in orange color, you can see over the 3 years follow-up, they are more likely to have more COPD exacerbation. So we have to combine these 3 factors, the spirometry classification, and in terms of axis, we have 2 axes. So we're going to confirm the spirometry using we confirm the diagnosis using a post-broncho FEV1 over FVC ratio less than 0.7. Based on the spirometry FEV1 predicted value, then we can further grade the COPD. But in terms of treatment option, we're going to use 2 parameters. Number 1, looking at the symptom. Number 2, looking at the exacerbation risk. Exacerbation risk, you're going to look at 2 things: frequency of exacerbation as well as the severity of exacerbation. So based on these 2 axes, the x-axis of symptom and y-axis of exacerbation, then we can further classify the patient to group A, B, and E. The old gold guideline divide into 4 groups: A, B, D, E. But now the latest guideline is only 3: A, B, and E. So A is defined those who have less symptom and low risk of exacerbation. Group B, those who have more symptom, those who have high symptom, define FMRC equal or more than 2, or CAT score equal or more than 10, but low risk of exacerbation. And group E is defined those who have high risk of exacerbation regardless the symptoms. Additional tests will be lung volume, especially those we suspect to have air trapping, and the best method to perform a lung volume assessment in COPD will be body plethysmography. Gas transfer of the SCO, especially those who have shortness of breath, disproportionate to the degree of the airflow, as well as those who plan for early stage lung cancer resection. Pulse oximetry or ABE is useful in those who have respiratory failure and plan for supplemental oxygen therapy. When we should do chest imaging, so chest X-ray should be performed to exclude alternative diagnosis and also to detect any comorbidity. For example, patient having heart failure or chronic lung changes that can explain the worsening symptom that patient have. In terms of CT, again, we perform CT scan to exclude other differential diagnoses, especially those who have frequent exacerbation and disproportionate symptom compared to their lung function test. Sometimes, if patient is planned for lung volume reduction, in fact, it's mandatory those who plan for lung volume reduction to have a CT scan. And normally, when in this group of patients, when we do FEV1, the FEV1 is less than 45% predicted. Most likely, this patient have emphysema, as well as lung cancer screening. In terms of prevention and maintenance therapy, you should include smoking cessation, pharmacological therapy that focus symptom and reduce risk of future exacerbation. We should advise patient the correct way to use inhaler, vaccination, pulmonary heart program, long-term oxygen therapy, and long-term non-invasive ventilation. In some patients, those Patients who have eczema, there are different methods of bronchoscopic intervention to improve patient symptom. And lastly, those have severe COPD and stage COPD in this group of patients, we should refer to our palliative colleagues. So the aim of stable COPD management is mainly addressing the symptom and future risk of exacerbation. I have to emphasize again and again, it's very important to advise our COPD patient to quit smoking. About 1/3 of our COPD patient still continue to smoke despite having a diagnosis of COPD. And our strategies should include both pharmacological and non-pharmacological intervention. This is algorithm how we should approach COPD. Once we diagnose patient, then we do the initial assessment, which is the latest gold ABE assessment, followed by the initial management, smoking cessation, both pharmacological and non-pharmacological intervention, and we should follow up patient and adjust our treatment based on patient response. So in terms of treatment goal, there are two things. Number one, to reduce symptom, and number two, to reduce future risk of exacerbation. Smoking cessation. So one of the quick way to screen your patient is to screen and help your patient to quit smoking is 5A. Ask patient about their smoking status. If they're an active smoker, you should advise them to quit smoking and assess whether they are ready to quit smoking or not. And the other thing that you can assess is to assess the nicotine dependence using a Fagerstrom questionnaire. If they agree or willing to quit smoking, you can help them by giving non-pharmacological and pharmacological help to quit smoking. And lastly, you can refer them for quit smoking clinic. So there are different inhalers available in market for COPD patient. Sometimes patient get confused. Doctor also get confused. One of the common mistake that done by patient, they are not using the inhaler correctly. I can
my asthma. They said they'd fix it, but it didn't make any difference at all.
Can you see my slide or not? So I don't know whether you can see my video or not. So in this video, you can see patient are not using the inhaler correct in a correct manner. He just using like a Darren, not using. This one you can Google lah, Dr. House. Dr. House incorrect inhaler technique. So I think patient always make this mistake. Please make sure in every clinic visit you have to reassess patient inhaler technique. How we can choose what is the best or the most appropriate inhaler for our patient? This algorithm introduced by Prof. Osmani, ACT, assess, choose, and train. So there are two ways to inhale the medication, either slow and steady. The other way is quick and deep. So those who can inhale slow and steady, this group of patient, you may consider a metered-dose inhaler or soft mist inhaler. Those able to deep and quick and deep inhalation, you may consider to use dry powder inhaler. So make sure you assess patient first. When you assess the patient, then you can choose which inhaler is most appropriate for your patient. And lastly, do not forget to teach your patient how to use the inhaler. There are 7 steps to use inhaler. Number 1, make sure you prepare, prime the inhaler. Make sure the patient exhale first before they inhale. When they place the inhaler tight over the mouth, make sure there's no leak, and inhale either slow and steady for metered-dose inhaler or soft mist inhaler, and those using dry powder, make sure they inhale quick and deep. Make sure after the inhalation, they hold their breath for 5 seconds. And lastly, close and repeat the procedure, especially those require 2-part. Make sure patient are happy and you are happy with the inhaler. There are objective way to assess the inhaler resistance. The device that we use is in check down. So in this device, based on the resistance, whether patient able to inhale forcefully or not. Those who have low resistance, you may consider device to have low resistance, for example, meter-dose inhaler. Those able to inhale against high resistance, you may consider the dry powder or turbohaler device. So once we categorize the patient into group A, B, and E, then we can choose the initial pharmacological treatment for this group of patients. For those who in group A, less symptom and low risk of patient, can choose a bronchodilator. It can be short-acting or long-acting. For long-acting, you can either choose long-acting beta agonist or long-acting antimuscarinic. Group B, those who highly symptomatic but low risk of exacerbation, you should in this group of patients you should give dual bronchodilator, long-acting beta agonist and long-acting antimuscarinic agent. And group E, frequent exacerbation, either you can give dual bronchodilator or triple therapy. Dual bronchodilator plus inhaled corticosteroid in those who have high eosinophil count, more than 300 cell per microliter. So these are the new changes. Dr. Jamalu mentioned in earlier in Goal 2022, there is group A, B, C, and D. Now in 2023, there's no group C. So group C and D is combined to group E. Those who have frequent exacerbation. The other things, the other new changes in the latest goal recommendation in 2023, in the old goal 2022, there's no triple therapy upfront. So you should not give triple therapy upfront. But now in goal 2023, you can give triple therapy upfront as initial pharmacological option in those who have high eosinophil count. Okay. These are the new changes in the latest goal recommendation 2023. Again, once you decide, then you review, assess, and adjust, and you should follow this cycle in every follow-up. So the table or the graph that I showed you earlier is the initial pharmacological treatment. For follow-up pharmacological treatment, we're going to use a different algorithm. So we're not going to use ABE anymore. For follow-up, we're going to see whether the patient is symptomatic of frequent exacerbation. Those who respond well for the initial treatment, we should maintain it. But those during follow-up, there's still dyspnea or they still have frequent exacerbation, you're going to use separate algorithm for each presentation. Those who have dyspnea, those who have persistent shortness of breath, if the initial treatment you are using a single bronchodilator, you should use a combination of LABA, LAMA, dual bronchodilator. If patient already given dual bronchodilator, despite this, patient remain shortness of breath, so you may consider changing inhaler device or molecule. Initially, you may choose LABA-LAMA combination in terms of powdered inhaler. Maybe in the next follow-up, you may consider to change to a soft mix inhaler. In some patients, you may escalate to non-pharmacological treatment, and you want to investigate or treat other causes that can explain the shortness of breath. This for those presented with shortness of breath during follow-up. Those who have frequent exacerbation, with the initial treatment, if you give bronchodilator, either LAMA or LABA, next what you should do, you should check at the blood eosinophil level. If the blood eosinophil level is high, more than 300 cell per microliter in this group of patients, you want to give triple therapy. So those who have frequent exacerbation, high eosinophil count, you want to give triple therapy. Those who have exacerbation, you are using single bronchodilator at the initial treatment, and we check the blood eosinophil count is less than 300. In this group of patients, you want to consider using dual bronchodilator. Still, they have exacerbation. Again, you can check the eosinophil count. If the eosinophil count is higher, now at this point, more than 100 cell per microliter in this group of patients, you may consider using triple therapy with additional of inhaled corticosteroid. If the eosinophil count is still less than 100, you want to maintain the dual bronchodilator, but now you have the option of using roflumilast or azithromycin. Roflumilast in those who have FEV1 less than 50% and history of bronchitis, and azithromycin those who is a former smoker. Remember, so the initial pharmacological treatment is different. The follow-up pharmacological treatment is different algorithm. During follow-up, you should no longer use ABE table. You should use different algorithm based on the treatable trait, either dyspnea or those who have frequent exacerbation. What are the factors that you want to consider when you want to start inhaled corticosteroid? So, inhaled corticosteroid is strongly favored in patients who have frequent COPD exacerbation. You find those who have history of hospitalization for COPD, or those who have 2 or more COPD exacerbation per year, those who have high eosinophil count, 300 cell per microliter, and those who have history of concomitant asthma. It can be used in those who have 1 moderate exacerbation per year, and the eosinophil count is between 100 to 300 cell per microliter. And we should not use inhaled corticosteroid in COPD patients who have repeated pneumonia event, those who have low blood eosinophil count, defined as less than 100 cell per microliter, and of course, those who have history of those who have history of TB. So these 3 group of patients, repeated pneumonia, low eosinophil count, history of TB, we should not use inhaled corticosteroid. Don't forget the non-pharmacological treatment of COPD consists of smoking cessation, physical activity, and vaccination. For our local recommendation, the vaccination is 3, which is influenza, pneumococcal, and COVID-19 vaccination. So influenza is yearly vaccination. Pneumococcal, for those aged less than 65 who have COPD, they should take once either polysaccharide vaccine or conjugate vaccine till the age of 65. After 65, those who take polysaccharide vaccine, they should repeat the polysaccharide vaccine every 5 years up to 3 times. And those now, because we live in the COVID pandemic, we should advise all our COPD COPD patient to take COVID vaccination. Pulmonary rehab, self-management, and integrative care of COPD. Pulmonary rehab show that it improves shortness of breath, has status, and exercise tolerance in stable patient. Not only that, pulmonary also reduce hospitalization in COPD patient. Also reduce symptom of anxiety and depression. Self-education and management is not limited to asthma, also play a role in COPD patient. Having this intervention can improve patient health status and decrease hospitalization as well as emergency visit. And those who have severe COPD, at the end of their life, we should refer this group of patients to our palliative colleagues, whereby opiates, neuromuscular electrical stimulation, oxygen, and fan blowing to the face can help in terms of shortness of breath. We should address patient nutrition as well. That can improve the respiratory muscle strength as well as the overall status. And fatigue, one of the common symptoms of severe COPD patient, can be improved by self-management education, pulmonary rehab, nutrition support, and mind-body intervention. Please refer your severe COPD patient, those at advanced stage, to our palliative colleagues. This table shows different surgical and bronchoscopic intervention that we can offer to COPD patients based on their symptoms. Either they have chronic mucus production, exacerbation, and dyspnea. Based on the presenting symptom, there are different ways, either surgical or bronchoscopic intervention to address this symptom. This is the algorithm how to choose the appropriate bronchoscopic intervention or surgical intervention for this group of patients. You don't have to memorize this algorithm. Just remember, if you have COPD patient who are suitable for this intervention, please refer them to a respiratory clinic, and we'll do the necessary investigation, and those who are appropriate for the intervention, going to refer to Dr. Jamalul to have this intervention performed on them. And this picture show the different bronchoscopic intervention performed in Sedang Hospital under Dr. Jamalul and his team. So you look at the your left side, there is a